What's that? Very good, thank you. Okay, so the first question is, you are discussing with a medical student the upcoming gastric tooth placement and missing fungification surgery in an 8-year-old boy with spinal muscular atrophy type 1, also known as Wernicke-Hoffman. The student remembers there is an association between neuromuscular disorders and malignant hyperthermia. Of the following, the information regarding malignant hyperthermia that you are most likely to share with the student is that DNA testing can identify all susceptible patients. It occurs most commonly in adults. It occurs only with the use of halothane. It usually is inherited in an autosomal recessive pattern, or E, the mortality rate is less than 5%. D's not correct.
E.
E, very good. And we'll talk about that. So basically, this is a rare but an anesthetic emergency. It usually is induced not only with inhalation anesthetics, but also with the addition of depolarizing muscle relaxants, and not always just halothane, it could be others as well. They typically get a clinical pattern of a massive respiratory acidosis, usually marked by rising end-tidal CO2 during surgery, metabolic acidosis, hyperthermia, tachycardia, hypertension, muscle spasms, particularly in kids, masseter spasm, and rhabdomyolysis. Even though they thought the inheritance pattern was as discussed in answer D, they believe it now is more of a multifactorial type of inheritance. This disease is associated with various amounts of neuromuscular conditions like central core disease, King-Denborough syndrome, various types of myopathies, sometimes hypokalemic periodic paralysis. So those are the high-risk type patients. So even though this patient has SMA, typically is not one of the concerns. Okay. Next case, a 1-week-old is brought into the emergency room with increased work of breathing and poor feeding. On exam, he is cyanotic, lethargic, and tachypnic with retractions. The cardiac exam is noted for tachycardia, poor pulses, and cool extremities. Blood pressure is unobtainable. Among basic labs, you obtain the following chest radiograph. Your next best step is to administer fluid bolus, ampicillin and cefotaxime, hydrocortisone, prostaglandin E1, or E supplemental oxygen. D, very good. So the content specification here is recognize factors associated with a cardiogenic shock in children of various ages. We're also going to talk about planning a diagnostic evaluation of cardiogenic shock and also the appropriate management. So really, this entails mostly the disease processes known as critical congenital heart disease in kids. These are typically ductal-dependent lesions. They could be either systemic blood flow or pulmonary blood flow dependent type lesions. This is where basically the right ventricle is the main ventricle that's pumping blood through the ductus to maintain systemic blood flow. The classic ones that we look at usually in the situation that we want to catch in the newborn period includes hypoplastic left heart and, of course, all the terrible T's that we talk about. But here we're just going to talk about coarctation of the aorta, interrupted aortic arch, and also critical aortic valve stenosis. If, as in this patient, you suspect a critical congenital heart disease, meaning it's a ductal-dependent lesion, the most important thing is to start prostaglandin E1 right away. Actually, giving oxygen will make things worse because you'll start stealing blood away from systemic circulation to pulmonary blood flow. Next case, a 3-month-old presented to the ER because of decreased activity and poor feeding for the past several weeks. The parents state that the child has not had a fever, has not been hospitalized previously, and has only been followed by their pediatrician for poor weight gain. They report that he has had intermittent cough that is mild but no nasal discharge. The boy's temperature is 37 degrees, heart rate 150, respiratory rate 45, and blood pressure 65/40. His peripheral pulses are palpable but diminished. He appears to be in moderate distress with coarse bilateral breath sounds. You will obtain a chest radiograph. The emergency department staff obtains laboratory studies including blood cultures and administers a total of 40 ml per kilo of isotonic fluids and antibiotics. However, the infant becomes less responsive with a heart rate of 170, respiratory rate 60, and blood pressure now down to 50 over 28. His peripheral pulses are now very difficult to palpate. You get a repeat chest x-ray which shows the following. Of the following, the most likely cause of this boy's shock is bacterial pneumonia, congestive heart failure, hypovolemia, sepsis, or E, viral bronchiolitis. Very good. Okay, so again, we're going to talk about the heart failure aspects in shock. So if you look at the classification of shock, there's various types. Hypovolemic shock is typically when you have a decreased circulating volume, and it can be caused by multiple things. It can be, most commonly, if it's traumatic, it's going to be hemorrhage. Otherwise, it's most likely going to be due to volume loss due to GI losses such as diarrhea. Other cases that can cause hypovolemic shock includes DI, diabetes mellitus, meaning DKA, any kind of burns, adrenal genital syndrome, and capillary leak. Distributive shock is when you have vasodilatation, venous pooling, and decreased preload. Okay? Or you can have a maldistribution of regional blood flow. Common causes, the classic one is sepsis, but also keep in mind anaphylaxis. Any kind of CNS or spinal cord injury can lead to this, and of course, various types of drug intoxications. Cardiogenic shock, such as this patient that we're talking about, is usually due to a decreased myocardial contractility. Classic ones, congenital heart disease. Don't forget your arrhythmias, hypoxic ischemic insult, cardiomyopathies, any form of metabolic derangements, including inherited ones, genetic ones, drug intoxication, and then, of course, Kawasaki disease. Remember, Kawasaki disease is probably the most common acquired coronary artery steal phenomenon that you're going to see in kids. As far as obstructive shock, this is related to cardiac, but it's basically when you have a mechanical obstruction to ventricular filling or outflow. Classic ones include cardiac tamponades, such as those with pericardial effusions, a massive pulmonary embolus, any form of pneumothorax that's under tension, and of course any kind of cardiac tumor. And finally, dissociative shock is when you have a problem with oxygen utilization, meaning oxygen can be brought to the cells but isn't either released or used by the cells appropriately. Common causes, carbon monoxide poisoning, cyanide toxicity, and of course methemoglobinemia. As far as why this patient developed heart failure after the fluid administration, just recall that if you look at the Frank-Starling curve, the green line shows you normal pattern when you add volume. So as you add volume, the stroke volume increases, and so does preload. However, when you have heart failure, you have more of a flat line, such as the red line noted in this picture. And when you add more volume, the stroke volume doesn't really increase very much, to the point where it falls off the end of the curve. Also, too, these patients with heart failure are very sensitive to afterload. Again, showing stroke volume on the left side. The black line shows you a normal heart, and that how with hypertension or increased afterload, the stroke volume will decrease. The severe heart failure line, noted in red, is more of a flatter type line. Again, does not really improve with any kind of afterload. In fact, you get immediate decompensation with afterload, and therefore you want to try to reduce afterload in these patients. So our initial treatment of cardiogenic shock, we want to stabilize these kids from a respiratory standpoint. We want to provide diuretic administration, again, to decrease preload, and then initiate any kind of inotropic medications. Once they're stabilized, there's two mainstays of treatment. We have pharmacologic therapy, and we have nutritional intervention. As far as pharmacologic, again, you want to continue to decrease preload by giving diuretics. You want to decrease afterload by providing some afterload reduction agents, such as ACE inhibitors, if it's not contraindicated. Sometimes we'll use inotropic agents in those situations, such as digoxin. We tend to use more of the beta blockers, such as carvedilol in the older kids, but this all depends on the patient's clinical status. The other mainstay of treatment is nutritional support. Remember, these kids, such as this patient that we reviewed in the last case, or in this case, had poor growth, okay, most likely because of increased metabolic demands, because of increased respiratory rate, etc. And so they're going to need more calories to try and grow. And so you have to provide extra nutritional support. If they're getting breast milk, make sure it's fortified, or if they're not taking breast milk, you're going to have to use formulas that have higher caloric density, such as your 30 calorie per ounce type of formulas. As far as septic shock, these presentations will be provided for you. I'm not going to go through this completely, but just realize that when you have septic shock, you want to identify those kids with septic shock right away, provide appropriate antibiotics, reverse the perfusion abnormalities as quickly as possible, and therefore improve outcome. This is the pediatric algorithm, and this one is for neonates. The one difference on the neonate one that I want to point out, though, is that they talk about ductal-dependent lesions. So if you're running into a recalcitrant type of septic shock patient that's a neonate, consider also ductal-dependent lesions. You might have to start prostaglandins. Next case is a 15-year-old girl who presents to the PICU for a suicide attempt after taking 20 extra-strength Tylenol tablets, and they're basically 500 milligrams per tablet. She complains of nausea and has had one episode of vomiting. On presentation, she's awake and alert with stable vital signs. Her exam and laboratory values are normal, except that she does have elevated liver enzymes, meaning her AST is 300 and her ALT is 350. You start activated charcoal and begin antidote therapy with mucimist, which is basically N-acetylcysteine. Within 24 hours, she has less nausea. At 72 hours, however, her transaminase levels are decreasing after she hit a peak of 1,000 and 950, respectively. Despite this, she continues to have an elevated INR of 4 and a bilirubin of 5. The most likely explanation for this is Wilson's disease, hepatorenal syndrome, hepatic failure, cholecystitis, or E. hepatitis C infection. C, very good. So the content specification is recognize the signs and symptoms of impending hepatic failure. So if you look at her table here, this can look like any kind of hepatic failure type patient. When you start to see a decrease in the liver enzymes, however, your liver quote-unquote function is not improving, like your INR and your coags, that typically means that they've burned out pretty much all their liver cells and there's no more enzymes to leak out. Okay? And so when you see this type of pattern clinically, usually means they're moving towards hepatic failure. Okay? Again, hepatic failure either occurs from a massive acute necrosis of a large amount of hepatic cells, as we just described, or a sudden loss of hepatocellular function. Typically, the synthetic, excretory, and metabolic functions are impaired in one way, shape, or form during these processes and progress to fulminant hepatic failure. All these things noted here, such as bacterial translocation, cytokine release, etc., will occur during hepatic failure in these children. Symptoms you'll see, such as our patient, nausea, and vomiting, fatigue, anorexia. Jaundice is a classic thing, and ascites. They often will have altered behavior. The one classic thing that you'll see in these kids, especially if they're older and they have verbal skills, is this belligerent, foul language type behavior, saying things that typically do not come out of the mouths of kids. Okay, so look out for that. It's very concerning. They often will also have an increased tendency to bruise easily. Again, you want to delineate the difference between hepatic injury and hepatic dysfunction. Injury is typically when you just have elevated liver enzymes. If the patient in this vignette totally got better and didn't have any other problems, that's most likely what this patient had. However, she has dysfunction because she had the coagulopathy, meaning the markedly elevated INR, despite her liver enzymes getting better, and also she had the rising bilirubin. Okay? Other things that you might see in hepatic failure, in addition to that, hypoglycemia, low cholesterol, and of course hyperammonemia. Remember, the liver filters a lot of that output from the gut, and then it rises because of that. They also get the encephalopathy, as alluded to in the last slide. Okay. Next case is a adolescent admitted to the ICU for diabetic ketoacidosis. About 3 hours after treatment, he developed altered mental status, marked by no eye opening, no verbalization, and flexion only to painful stimuli, so a GCS of 5. He has increasing respirations. His heart rate has decreased from the time of admission to now from 120 to 70, and his blood pressure has increased from the time of admission from 80/60 to 140/100. His eye exam reveals a unilateral dilated pupil. The change in this patient's mental status is most likely due to toxic ingestion, hyperosmolar coma, meningoencephalitis, elevated intracranial pressure, or brain death. Very good. Okay, so the content specification is understand the criteria for brain death and the role of neurodiagnostic studies in making that determination. So these are the brain death criteria that have come out back in 2011 for children. The last time they revised this was back in the 80s, so this is a welcomed guideline. So the things to look out for, again, you can pull this up to see a little bit better. The first thing that you want to make sure is that they don't have some form of reversible condition that's looking like brain death. Okay, and you want to make sure that those are all excluded before you start to do any kind of testing. Okay. Other things to keep in mind is that their temperature should be near normal. They shouldn't have any kind of sedatives or muscle relaxants on board that might skew the picture. Okay, and they need to be at least eunatremic. Okay, otherwise this might be a confounding exam. If you rule those things out, the next thing that's okay. The next thing that you want to do is establish that they do have a coma. Okay, and this is marked by a complete loss of consciousness, vocalization, and volitional activity. Because this kid was moving a little bit, I already ruled this kid out as being brain dead. Okay, but I'd like to go through the rest of the criteria just so you know what else to look for. Because if any of these things are present, okay, then the kid is not brain dead. The other thing you have to establish is that they have a loss of various types of brainstem reflexes. Okay, an example up here includes the mid-position, fully dilated pupils. This kid only had one dilated pupil. Okay, he may have been moving towards brain death if he herniated, but in this situation still is not brain dead. The other thing you're going to look at is if they're apneic, meaning they don't have any response to elevated CO2 and therefore do not respond from a brainstem reflex to any kind of challenge of hypercarbia. And finally, they have to be flaccid. Again, as alluded to earlier, this kid was moving somewhat. Even though it was a normal movement, they're still moving. If they have flaccid tone and absence of spontaneous or induced movements, then you have to consider they may be moving towards brain death or have brain death. Again, you have to complete all these criteria before you decide that they may have brain death, and then the exam is followed up by another exam like this about 12 to 24 hours later. It depends on the age of the kid. If it's a young baby, like a newborn, up to about 7 days of age or so, we're going to be doing, typically 24 hours. Kids after the age, typically about 24 hours. I'm sorry, 12 hours. 12 hours. So older kids, 12 hours you wait. As far as the ancillary testing, as delineated by the content specifications, those are considered to be useful if you really can't establish brain death. Okay, things that we use include EEG and radionuclide cerebral blood flow. This is a little bit different than adults. With adults, we typically use 4-vessel cerebral angiography. With kids, we don't. We typically use EEG and cerebral blood flow because technically it's much easier to do. So if you can't tell if the patient for sure is brain dead, you can use EEG documentation of either electrocerebral silence, or you could do blood flow determinations. Either way, that'll add as ancillary testing to your brain death exam. Again, if the brain death exam is completely clear, then you don't have to do this. But these are the things that we do for pediatrics. Again, these are not my guidelines. This is from the ABP, okay, American Board of Pediatrics, asking for you guys to know this stuff. That's what I'm covering, okay? All right, next case, you are caring for an adolescent patient after a failed suicide attempt by attempt at strangulation. He was intubated due to persistent desaturation despite high flow nasal cannula and a trial BiPAP. Clinical and chest radiograph findings support post-obstructive pulmonary edema. So, in addition to supportive care and judicious use of diuretics, ventilator management would consist of using higher flow, FiO2, PEEP, pressure support, or E-tidal volume. PEEP, very good. So the content specification is know the value of PEEP in a patient with pulmonary edema and plan the management of various disease processes requiring mechanical ventilation. So in this situation, I'm going to talk about the use of PEEP. So the way PEEP works is by increasing the transpulmonary distending pressure. This helps by displacing edema fluid into the interstitium, decreases atelectasis, decreases right to left shunt, improves compliance, as well as oxygenation. As far as our clinical use, I just talked about some of the benefits. Let's talk about some of the precautions. It can increase your dead space for ventilation. It can also decrease cardiac output. What it does is increase pulmonary vascular resistance and decreases systemic venous return to the heart. If you don't have adequate preload, of course your cardiac output's going to drop and therefore blood pressure. Also, too, if there's over-distension from too much PEEP, okay, it may increase your VQ mismatching. So you got to be aware of it. So PEEP is good, sometimes not always good, especially if it's too much. 5-year-old presents with multi-system trauma. He has signs of shock due to presumed hemorrhage. While the patient is being intubated, he becomes hypotensive. The most likely reason for the low blood pressure is hypoxia, hypercarbia, hypovolemia, cervical spine injury, or E pain.
It's fine.
Okay, so who picks A? B or C?
C.
C. Okay, very good. So it's hypovolemia. Okay, so the content specification, understand the potential complications associated with endotracheal intubation. So these are all types of complications here, okay? Tachyarrhythmias or bradyarrhythmias, we typically see that latter in young babies. Impedes the systemic and venous return. We talked about that. It's the same kind of thing here. They can get hypertensive or hypotensive. They can get hypoxic, hypercarbia. They can elevate their intracranial pressure, intragastric pressure, or intraocular pressure. Other things you can have, structurally, it could cause injury to anywhere between the lips or nose all the way down to the alveoli. They may have aspiration because of regurgitation and vomiting. You can have inadvertent placement of the endotracheal tube into the esophagus or some other soft tissue or cranial vault. You can have cervical spine injury, as alluded to. I heard somebody mention about that. If they have high risk or actual cervical spine injury. And then, of course, you could generate a lot of pain and anxiety. This is particularly important, especially in a patient with elevated ICP. It can make the ICP worse. Other types of complications of intubation typically occur after mechanical ventilation is initiated. We use a dope mnemonic. Again, we alluded to some of these things, but I'd like to go through them. You can have displacement of your endotracheal tube. Okay, you can have obstruction, either with blood or mucus of the endotracheal tube. A pneumothorax can occur. Whether it's under tension or not, it can still significantly cause problems. And then, of course, you can have equipment failure. So again, think about these things as a complication and if they're on mechanical ventilation. Next case is a 10-year-old boy that has collapsed during school. He was in full arrest at the scene. Bystanders provided BLS. EMTs provided ALS. Upon arrival to your ER, he has no pulse, no respiration, no blood pressure. He's pale and dead appearing. He was fixed and dilated. You began pediatric advanced life support. You put him on a monitor, and it shows the following. You diagnose him with VFib. Your best next step is to provide defibrillation, DC cardioversion, epinephrine, amiodarone, or E magnesium sulfate. VFib. Okay, very good. So, main reason why I want to do that, this is a classic slide you'll see in PALS, but basically what it shows on the y-axis, the probability of survival, with the x-axis, the response to the time of defibrillation. So you can see that the longer you wait, the chance of survival is less, or drops dramatically in kids with VFib, to the point where it's almost down to 0 by 10 minutes. Okay, so the name of the game here, as soon as you see VFib, you got to defibrillate them. Okay? Certainly, that's not the only thing you do. Of course, you'll begin continuous CPR, adequate respirations for the patient, including adequate chest compressions. So you defibrillate with 2 joules per kilo, continue on for 2 minutes with your CPR. If you still have a shock or a rhythm, you can you defib again at 4 joules per kilo and give them epinephrine. Continue your CPR, give them 2 minutes with that. Check again. If they're still in that rhythm, you defib for a 3rd time, and you also give them amiodarone. Typically, we don't use lidocaine too much anymore, but if you have it available and not amiodarone, it's a nice substitute. The other thing to keep in mind is if they don't get better at this time, you go back to your previous defibrillation, meaning 4 joules per kilo and epinephrine. You never go back to 2 joules per kilo. If the patient has torsades, which is a type of AFib, not only do you go through this algorithm, you also give them mag sulfate. As far as the other types of CPR they expect you to know, pulsological activity asystole, again, we always start with really good CPR. Okay, we give them good ventilation, oxygenation, do adequate chest compressions, and we give them epinephrine. Then it's our task to look into the H's and T's that can be causing pulsological activity or asystole. They're listed here. Some of these kids can have multiple. Okay, if you think about some of your trauma kids, they can have hypothermia, they can have hypoxia, they can have hypovolemia, they can have acidosis, they can have tension pneumothorax, they can have all these things. Or some may just have a few things. Like we presented earlier, the kid with the hyperkalemia. It might just be hyperkalemia leading to this. So look out for these H's and T's. Certainly you can use those as guidelines if the other types of CPRs that you're doing are not going in the right direction. Search those out. They might be able to be reversible and help you out. So those are just the algorithms. Next case, a 14-month-old presents with high fever and increasing lethargy. On exam, the boy is toxic appearing and responsive only to painful stimuli. He has 30 peripheral pulses and cool extremities. His temperature is 40.2 degrees Celsius. Temperature 190, respiratory rate 60, and blood pressure 40/18. That's not a typo. His airway is intact, and his oxygen saturation by pulse ox is 94% on room air. Multiple attempts by EMS to establish peripheral IVs were unsuccessful, and actually 3 attempts by experienced ED nurse have also been unsuccessful. You order 100% oxygen by non-rebreather face mask for the boy. Of the following, the best next step in the management of this patient is emergent surgical consultation for a venous cut down, placement of an IO needle, placement of a femoral central line, placement of a nasal gastro tube for enteral hydration, or reattempt peripheral IVs by using ultrasound guidance. I'm sorry? B, very good. So the content specification is planned appropriate use of IO therapy. Okay? The main goal here is timely volume resuscitation and adequate reversal of perfusion abnormalities. That's in all comers. We're talking trauma, non-trauma, burn patients, it doesn't matter. All pediatric patients. Okay? You have to obtain rapid vascular access within 3 attempts or less. Okay? Some people say within 90 seconds, and if you can't get that and you're in extremis like this, you have to use an IO. Next case, a 2-year-old is brought to the ER after a drowning accident in a home swimming pool. Submersion time is estimated to be 2 minutes. He was resuscitated at the pool by a neighbor and by EMS en route to your facility. Upon arrival to you, he is receiving manual ventilation through an endotracheal tube. On exam, he's comatose, does not respond to verbal stimuli, and has non-purposeful flexion. His pupils are equal and reactive. His temperature is 35 degrees Celsius, pulse 120, blood pressure 100/60. His blood gas shows a pH of 7.08, CO2 of 42, O2 of 122, body carb of 12, and a base deficit of -16. Neurologic examination 12 hours later shows spontaneous eye opening, and he's now having purposeful movements excuse me, in response to verbal and tactile stimulation. So the question is, of the following, the best prognostic indicator of his future neurologic outcome is immediate CPR at the poolside and during transport, normal oxygenation, ventilation, acid-base status in the ED, normally reactive pupils in the ED, purposeful response at 12 hours, or E, young age. Very good. So content specification is understand the factors that predict the prognosis in a patient who has had a near drowning episode. Again, all these slides are here and the notes, so you guys can look at them at your leisure, but they all come from the content specifications. So in summary, really, there's no one factor to predict outcome. However, there was a study that was done that showed that kids that had favorable outcome usually had some form of purposeful, spontaneous movement within 24 hours. Those kids typically had normal behavior, normal mental status, normal background, or they had just minor defects. However, those kids that did not have spontaneous purposeful movement within 24 hours had poor neurologic outcome. Typically, they had spasticity, were in persistent vegetative state, or they had some lack of self-help skills, like feeding themselves, dressing themselves, going to the washroom, things like that. An 18-month-old fell into a swimming pool about 12 hours ago. Due to no heart rate, CPR was started at the scene. After 30 minutes, they were able to achieve spontaneous circulation. He's now in the ICU, on a ventilator, and receiving maximal critical care. Over the past few hours, his blood pressure has increased with persistent bradycardia, and he does not move despite being off of all sedation and off of all muscle relaxants. His pupils are dilated bilaterally, and they are not responsive to light. You obtain a bedside EEG that is noted for burst suppression with loss of reactivity to any kind of external stimulation. In discussion with his parents, you inform them these recent changes are most likely a result of agitation, increasing intracranial pressure, myocardial failure, ongoing seizure activity, or E, physiologic response to the ventilator. One more time? B, very good. Okay. So content specification recognize the clinical findings associated with cerebral edema in an asphyxiated patient. So the main process here is that this patient was hypoxic because of the drowning event. He had poor perfusion, so he basically has like a hypoxic ischemic encephalopathy type of picture, causing various levels of edema due to most likely either cytotoxic or vasogenic edema. The other thing that happens here is that these kids lose cerebral autoregulation. If you look at cerebral autoregulation curve, you notice that it's a process whereby the brain will allow us to have blood flow across a wide range of blood pressures. You notice that as the flat area between the pressures of 50 and 150. However, below that level and above that level, typically it's more of a linear relationship between cerebral blood flow and blood pressure. With these kids, when they have damage to their brains, they have a loss of cerebral autoregulation. So their curve looks more linear, such as the dashed line here that shows absent. So all blood flow is directly related to blood pressure, no matter where you're at. High pressures, low pressures, everywhere in between. Okay, so you have to try to achieve a higher pressure in those patients to provide a better blood flow. Anything below that, then they're going to have ischemia. Okay, next case. A 15-year-old boy is brought to the emergency department by EMS after crashing his all-terrain vehicle into a tree. The paramedics actually found him under the vehicle, but he was responding appropriately to commands. Following extrication, they immobilized his cervical spine, administered 100% oxygen by a non-rebreather mask, and inserted 2 large-bore IV catheters. On arrival at the emergency department, his temperature is 36.5, heart rate is 140, respiratory rate 42, and his blood pressure 80/60. He's now saturating 86%. He has a GCS of 14, bilateral femur deformities, marked right-sided chest wall tenderness, and crepitus. In addition, when he inhales, you notice that his chest wall on the right appears to sink in. Of the following, the most appropriate next step is to A, administer morphine for analgesia, B, obtain a chest radiograph with dedicated views of the ribs, C, obtain a CT scan of the chest, D, perform intubation and mechanical ventilation, or E, perform needle decompression of the right chest.
D.
Okay, one more time, A, D, or B? Okay, anybody for B? Anybody for D? Okay, D is correct. Okay, so the content specification here is recognize the clinical findings of hemothorax or flail chest. I decided to show you flail chest because there's a nice little video of it. Can I click on it here? Oh, we already have it. That's right. How can I show that? So one all the way to the left. There we go. You just click on it. There we go. And then hit play. All right, hit the middle of the screen. Now let's go down to. You might have to rewind it. Okay.
Click the one next to the pause.
Okay, I'll do it. Okay. Yeah. So that's what his chest looks like. So if you look up here, This is his nipple, here's the chest tube, and his head's up here. So this is the side of his chest. So you notice that you see this paradoxical type of movement.
Why would you not want to?
He's saturated 86% on a 100% non-rebreather. So he's not able to ventilate well, and he most likely has a pulmonary contusion underneath, and he's going to need some mechanical ventilation. Analgesia is important, but it's not the first thing to do in that situation.
So it's
Is it
ABC.
because it was morphine or just
No, just in
you
general.
don't even worry about it.
No, you want to do your ABCs.
ABC.
I can get you that done. You guys want to see it one more time, or you got it? That's on New England Journal of Medicine. Anybody can access that. Okay, it was actually from PrEP 2 years ago, not 2015, but 2014. Okay, so here multiple ribs are fractured at the same time, so it basically isolates that area, and you have an instability of chest wall. So there's a lot of respiratory compromise in these situations for multiple mechanisms. First off, as you saw that paradoxical movement. So when you breathe in, his chest should come out, not sink in. Okay. The other one, if you alluded to, is that you can have pain in the situation. Now, if his saturation were normal, I would say, maybe you can hang out for the intubation, maybe give him some pain meds, but eventually he's going to get intubated because a lot of these cases they're associated with pulmonary contusions, and they may even move into like acute lung injury, ARDS type picture. Okay, so really the treatment of flailed chest is supportive care along with adequate analgesia and assisted ventilation. Again, ABCs. That's why we intubate them and do mechanical ventilation first. All right, next case. A 6-year-old is admitted to the PICU for septic shock. During the first hour of admission, she receives a total of 60 mLs per kilo, so that's about 3 fluid boluses. It was isotonic saline. Her shock was manifested by poor perfusion and hypotension. At this time, she responds to verbal communication. Over the next 8 hours, she develops a progressive increase in alveolar arterial oxygen gradient. Her PaO2 is 88 while breathing 60% FiO2. Her chest radiograph reveals worsening lung infiltrates bilaterally. Her temperature right now rectally is 99.2. Her central venous pressure is 5 millimeters of mercury, and her pulmonary capillary wedge pressure, meaning her left atrial pressure, is 10. Of the following, the most likely underlying mechanism for her deteriorating respiratory status is fluid overload, increased pulmonary capillary permeability, left ventricular failure, progressive viral pneumonitis, or E, secondary bacterial infection. I'm sorry, one more time? You just say B or E? I'm sorry. B, very good, okay? So this kid has ARDS, all right? So the content specification is recognize etiologies of ARDS, recognize the clinical features of ARDS, and recognize complications of ARDS that can lead to death of the patient. Okay? So really, when you think about ARDS, the two etiologies are categorized either by some form of direct lung injury or some kind of indirect lung injury. The most common direct lung injuries that we're going to see are typically pneumonia or aspiration. Okay, either they weren't protecting their airway or they had some kind of massive aspiration type issue. Okay, another type that we often see, even though it seems less common on this slide, but we do see it a lot in our burn patients, is like inhalation injury, and of course we already alluded to the near drowning patients. So we see a fair amount of those patients versus non-trauma centers. So I'd put that up there as far as common ones that we see. As far as indirect ones, probably the most common is sepsis or some kind of severe trauma with shock and multiple transfusions, also known as transfusion-related acute lung injury or TRALI. Okay? That's going to be most common. What happens in those situations is that you have inflammatory response that happens to the patient, okay? And those cytokines travel to everywhere where blood goes, including the lungs. And once it gets into the lungs, triggers an ARDS type picture. One that we don't see here that's probably more common in heart centers are cardiopulmonary bypass. So if you go to a center that does a lot of congenital heart disease type of surgeries, you can see this as a phenomenon after cardiopulmonary bypass. Okay. So Dr. Cuppy actually gave a nice grand rounds this year about this, and I wanted to pass on this information that the criteria for ARDS has changed over the years. So for kids. So we want you to make sure that you can recognize it when you take the boards. Okay. So by definition, it's typically where you have a situation where there's an onset of this entity within a week of a known clinical insult, or there's a new or worsening respiratory symptoms that the patient's exhibiting. Okay? Also, their chest x-ray or CT of the chest, if you got one, is showing bilateral opacities consistent with pulmonary edema. And also, they have to have a respiratory failure that's not fully explained by either cardiac failure or fluid overload. That's why I mentioned the cardiac parameters. If the CVP was high and the pulmonary capillary wedge pressure was high, that can't be ARDS, okay? Because it's most likely heart failure. Now, the question I'm always asked is, well, Dr. Sutton, what if it's a cardiac patient with failure and they move into ARDS? Can that happen? Sure, they can. But you can't say that one is caused by the other, meaning the cardiac failure isn't causing the ARDS. Okay? As far as the abnormalities you'll see, it will categorize them into mild, moderate, and severe. So you basically look at your PF ratio, and typically if it's mild, it's 200 to 300, and they're on a PEEP that's greater than 5. Okay. At this time, if they're on non-invasive ventilation, that's okay. It could be, CPAP and things like that. Moderate ARDS is when you have your PF ratio get worse, and that's about where our patient was that we just described. Her PF ratio, I think, was close to 200, and where you have a PF ratio 100 to 200, and they have a PEEP or CPAP greater than 5. Severe ARDS, however, is when your PF ratio is much less than 100 and they're on a large amount of PEEP. So again, we typically will categorize them into these areas. Here's an example of bilateral infiltrates consistent with ARDS. This is an actual patient that came not into our system, but in general during the H1N1 outbreak that we had back in 2009, basically showing the infiltrates bilaterally. You notice also that the heart is not enlarged, so you don't see any kind of enlarged cardiac shadow. That's a clue that this may be pulmonary edema related to acute lung injury or ARDS. Again, based upon the content specifications, I want to go through the complications of ARDS. Typically, you can see multi-organ dysfunction syndrome. The most of them, however, you'll see is related to mechanical ventilation. You could see barotrauma, which is pneumomediastinum, pneumothorax. You might see some subcutaneous emphysema as well. You could see atelect trauma, which is typically the atelects that occurs in situations when you have high pressure snapping those alveoli open. It can cause shear forces causing injury. Or you could see overdistension type injuries such as volume trauma. Okay? In those situations, you have overdistension leading to excessive stress and shear on alveoli. Again, either way, both of these are considered ventilator-associated lung injury, which is a complication of ARDS. Another trauma that we see, what we consider more in the recent past, is biotrauma. This is where you have those cytokines we talked about that occur during ARDS that increases the amount of fibrosis in the lungs, leading to a chronic fibrotic lung disease, almost like BPD in our RDS patients. Okay, and so you can see biotrauma in these patients is quite significant and can be a long-lasting complication of ARDS. A couple more cases, and I think we'll be done. Or actually, this might be the last case. A 12-year-old girl presents 2 weeks after onset of viral respiratory illness. She recovered from the illness 8 days ago, but now she complains of chest pain, shortness of breath, and fatigue. On exam, her heart rate is 110, respiratory rate is 28, blood pressure 75/45, and her oxygen saturation is 95% on room air. The pale girl exhibits tachypnea, muffled heart tones with an obvious murmur, a palpable liver 3 centimeters below the right costal margin, and poor peripheral pulses. Sound familiar? She has minimal